Dude, we'll fish it out of you.
There you go.
Who do we got with us today? I'm gonna let you introduce the episode today. This is your guy. You guys go way back.
Guy, Steve Schiess. He's a family nurse practitioner specializing currently in geriatric care as a holder of many hats. And I think he's going to give us a really good understanding of how we treat the patient as a whole and how we look at taking care of our geriatric patient population, as well as kind of insights to how he found his way into becoming a provider. So really excited.
And the correlation between geriatric care and veterinarian care.
Yes. Right? And we might talk a little bit about chihuahuas and catheters. And
I can't wait.
Yeah. You need to stay tuned for this one.
All right, let's get it going. Welcome back to the show, folks, ladies and gentlemen. Happy to be back. Tyler, who do we got with us today?
Drop the hammer. Today we have none other than Steve Schiess, family nurse practitioner, humanitarian, nurse educator, home health nurse, father, husband,
fly fisher.
Mm-hmm. Yep. I mean, the list goes on.
And you two might know each other, right?
Yeah, we spent a little bit of time together. Yeah, we had the privilege of hanging out on one of the major hospitals' med-surg floor for a long time, taking care of neurosurgical orthopedic patients. We got to know each other really well.
Yeah.
And it's been a privilege to know you, my friend. In fact, something I did want to say right out of the gates, this guy right here is the reason I'm here.
I was going to say, I got you your job, I think.
100%. Let me landscape this for you. One day we're on the floor, and I'm working the floor, and he's working as well. And I was on like the opposite end. I was far away from him, if I recall. But like, he made an effort to come find me where I was at. He's like, look, Dr. Edwards just left his former practice. He's starting his own practice, and he needs another advanced practitioner. He's like, that's you. I'm like, oh, really? And so, kind of giving you some background there, like Dr. Edwards and I had talked, but it's very brief, about patients that I had taken care of. So I didn't really know Dr. Edwards that well. However, Steve, being the outgoing guy that he is, did know Dr. Edwards really well. And so he was able to make that connection. And lo and behold, I messaged the APP and Dr. Edwards at the time, and eventually got an interview, and then got signed on about 2 weeks into inception of Summit. So
add matchmaker to the list.
Matchmaker.
Yeah, matchmaker. There you go.
Yeah.
Well, I always tell Tyler, I'm like, you owe me a job, man. So one of these days, I'm gonna hold him to it and be like, hey, you're holding, Summit, bring me on.
Let me tell you, my guy, you're holding way too many hats to try to take on another hat, my guy.
Oh, it might be kind of fun.
I love it.
I love
it.
What are you doing right now, Steve? Tell us what you're doing. What kind of setting you in? Where are you at?
So mostly geriatric patients. I manage patients that come out of the hospital and skilled nursing facilities. So a couple facilities here in Utah County. The patients come out, they're unable to go home following surgery. Mm-hmm. So surgery or you name it, heart problems or gastrointestinal problems, whatever. They come out of the hospital, they're unable to go home. They have to go to a skilled nursing facility to receive some acute rehab. The main focus is physical therapy and medical stabilization. So I'm the medical guy. I try to help stabilize them for about 20 days is what their insurance will pay for, and then set them up to continue to progress and go home. And so that's one thing that I'm doing right now.
Yeah.
That's my main job. I'm also involved with there's a nonprofit group here in the United States. It's called Co-Imagine Health. They help skilled nursing facilities manage opioid safety. And so I'm on a safe opioid council throughout the state of Utah with them, and I've presented at a couple conferences and stuff about opioid safety and things like that. And then just trying different things. Got my hat in some humanitarian stuff, got my hand in some home health consulting stuff. I mean, it's just kind of fun.
Staying busy. I love it.
Nurse practitioner, it's cool because I can do so many different things that I've always wanted to do. So
I love it. I'm impressed by that. Tell me about the skilled nursing rehab world, though. I actually, until about whatever that was, a couple months ago, we went and did a site visit and went and saw one of the local facilities. I never had actually stepped foot in one of those buildings before.
Yeah, it's a whole new world.
It's different. It's unique.
Yeah, it's
Give us some insight into that.
Yeah, it's
What
crazy
is
too,
different
is-
about this setting?
Well, what's crazy too is that I also have the Utah Valley residents. They actually come with me on rotations to my skilled nursing facilities. We've been doing that for about a year now. And at first I was like, man, I'm a brand new nurse practitioner. Like, what am I going to teach these medical doctors? I mean, they're already a doctor. This is their second year of residency. I'm like, what the heck am I going to teach them? What's interesting is they don't teach them in medical school about skilled nursing facilities.
Yeah. Yeah.
Like, no one has any idea what goes on there. So when they come, it's like a deer in the headlight look, and they're like, whoa, you do all of this? And so all of this is kind of, so we manage patients. Mm-hmm. So 20 days is what Medicare gives a typical patient that's over the age of 65, gives them 20 days paid in a skilled nursing facility. At day 21, they have a copay, and it's anywhere from $100 to $400 that they have to pay to stay there longer if they need to. So 20 days is basically what I try to do to get my patients out.
Right.
Stabilize, get them walking, get them to their next step is what I call it. It doesn't always mean home, just their next step, whatever helps them continue to progress.
Where else would they be going?
Well, like...
you putting them out on the street or
no,
what?
Heavens, try not to. No. Cancel that. No, but like home, so you have to think.
You're saying like with a family member or home independently
Family member,
or...
home,
Yeah.
Private caregivers, assisted livings.
Sure.
If they can apply for Medicaid, they could go into long-term care. That's a whole new beast.
Okay.
That's a whole other thing.
So
too,
there
right?
are options for them to go.
There
Okay.
are
Not
options.
to the
We're
streets,
not
Alex.
setting
Not
them
to
home on
the
the street,
streets.
right?
Yeah.
But it's a very interesting dynamic. So I would say like 70% of my time is with the patients.
Okay.
30% of my time is with the patients' families. And then managing somewhere in a couple percentage of the time, trying to manage relationships with these skilled nursing facilities that I don't work for, that I'm there as a guest, but that I'm helping them manage patients and give a little bit higher level of care to these patients. And the family part, the family dynamic is really interesting because you think, okay, we just have to deal with patients, right? And all their things that happen. And I love working with these patients. But then I also have to add that dynamic of explaining to the family member why their mom has cognitive processing issues after I did a MOCA on her, which is a cognitive processing test. And they're a 15 out of 30 on this cognitive processing test, which means they're not safe to go home by themselves.
Yeah.
But mom was living by herself for the last 30 years, and she's had continual falls. And now family members are like, well, why can't she go home by herself? Well, she can't remember to take her medications appropriately.
Yeah.
She's falling down the stairs. Like, are you guys going to step in and help? Are we going to bring private caregivers in? Are we going to go to an assisted living? Or do we need to look at something else? Yeah. So there's a whole dynamic there that people are like, and these medical students, when they come in, they're like, you meet with the families one-on-one for care conferences every day? And I was like, every day that I'm there, I do. Because I want to make sure that it's safe. Right. My whole thing is safety for these patients.
Yeah.
What is safe to send mom home? What would be safe to send my mom home if she had these things? What would be safe to send your mom home or your dad home if they had these certain cognitive issues or physical issues, or they're not able to navigate stairs, or they're not able to navigate taking their own medications appropriately?
Yeah, I love that.
So it's a super big navigation to try to figure out what is safe for my patients so that they can continue to progress.
I love seeing you restoring some faith back in the system that people and providers really are looking out for someone's best interest and actually do care.
It's fun.
It's hard on the patient side of things. I know it and I've seen it. You can just see it in somebody's eyes when they do not fully trust that you have their back. They have probably been let down at some point. Somebody else has let something slide at some point. It's nice to see somebody restoring some of that faith in the system that you've got their best interest in mind. You're really trying to take care of people.
And this was an area of medicine I had zero idea this even existed. I got out of the MP school and I thought I need a job. and I don't have a job. So I'm going to apply to any job. And I work for Intermountain, and I was like, I'm going to apply for any job at Intermountain. That's a nurse practitioner job.
Right.
I don't care. I can learn it. Not a big deal. Love to be an ortho neuro. Love to be something around that because I'm passionate about that, but I'll do anything. And then I got in the interview, and I was like, what is this job? Like, I had zero idea what it was, but never thought that I'd love something like this, but I do. It's great. I get to talk to people all day long. 50% about medical stuff and 50% about fishing, you know?
I bet they eat
or
that
whatever.
up.
I eat it up. Like, it's
yeah.
great. They eat it up. We love it. It's great.
Yeah.
This guy was just talking about being challenged, biking his way up the canyon. And he said, there's no way I could do it because I'd see way too many fishing spots that would take my attention away. I would never make it up the mountain. This guy's an avid fisherman. So listeners out there, if you want to go fishing, I'm sure he'd take you.
Sure,
He's
let's
asked me
go.
for the last several years, and I haven't done it yet. But you
This
and I,
year,
buddy,
we're going
to do it.
We are.
No doubt
We
in my
will.
mind.
Yeah.
You know, switching it up a little bit, just this idea of becoming a nurse practitioner, I think you kind of saw me kind of go on and get my nurse practitioner license, and then you yourself had aspirations to do so. But what was the real shift like in your mind to do that? Was there a moment where you were like, hey, because I think about all these nurses on the floor, and you know, I see them, you know, people we've worked with, and then you see them and they're still doing the same thing and they love it. But like for some of us, it's like it's just not enough. We want that next role. And then to think about what you just explained as far as your autonomy and what you're doing now and how much you're in control of, does that stem from kind of your experience on the floor?
Yeah. So let's go back real quick. Before nursing.
Getting in the Wayback Machine.
Okay, we're getting the Wayback Machine here.
Okay.
Hot tub
Did you all
time
know
machine.
that I was a vet tech for 10 years?
I knew that.
I was a
did.
veterinary technician for 10 years. I worked with animals, man. Humans were not on the list. Matter of fact, I was so scared of human blood. I was like, I can't do that. Like, I did surgery. I did neurosurgery on dogs. I did orthopedic surgery on dogs. I mean, I did it all on animals. You know, cows, sheep are the easiest thing to draw blood from. Just FYI, if you ever want to draw
to
blood
know.
from a sheep.
Good to know.
Yeah,
Yeah.
good to know, right? So never thought that. Had an experience at the University of Utah where I had to help a lady that got hit by a bus. And I was on this bus full of nurses and doctors. And whatever happened, they didn't want to touch her because they didn't have gloves on. And I was like, she's bleeding out of her leg. So I threw my sweatshirt around her and propped her leg up on my shoulder as blood's pouring down me. Human blood.
Oh,
you know,
man.
freaky, right?
Mm-hmm.
And then that kind of set the tone. I was like, I can do this. Like, this is the same thing I do with a dog. And when I couldn't get into vet school, I tried for 4 years to get into vet school. Couldn't get in. And I was like, what the crap? Like, this is stupid. Like, I got 10,000 clinical hours in a clinic.
Yeah.
I can put a catheter in a chihuahua. Like, come on, man. Like,
That's
what the
terrible.
heck?
Have you really
know?
done that?
Oh, 100%. Oh, 100%.
I love
Cats are even harder. They got this weird femoral vein that you got to shove it. Yeah, it's crazy. You shove a 24 gauge catheter in there. But my wife asked me, you know, and this kind of sets the tone of where we're going is my wife asked me, she said, if there was no such thing as vet school, what would you do? And I said, well, I'll use my skills. I can stick a catheter in a chihuahua. I was like, how many nurses can do that? And she's like, right. Go to nursing school.
Yeah.
And I was like, okay. And I did. And that set the tone, and I loved it, you know. And I could never figure out when I was a vet tech, these doctors, these vets, they'd be like, Steve, will you go and explain to the dog's parents, like, what happened during surgery? Because we don't want to. And so they shoved me out there as a vet tech, and I go and explain the whole procedure, and this is what we did. And I was like, why are they doing this to me? Set me up perfectly for nursing, right? I'm a nurse. Tyler and I have, oh, man, there's some stories.
I can't wait. Hopefully you got one loaded up for us. You got one loaded up for us?
For me and Tyler?
Yeah.
So
he's going to spill the beans on you today.
So
Man,
I
we're getting
am.
into it
Real
right
quick.
now.
No,
right
yes.
it doesn't have to be right now.
He wants to do it. Let
I
him
mean,
do
it sets it up,
Okay.
Tone.
All
We're
right,
just moving along the path here.
Let's.
I mean,
get
we
it.
already
so-
learned about the wild wiper.
Yeah, what? Oh, did we?
Did
learn
you know that
what?
story?
Oh yeah, well I set him up to that story.
Okay.
If it's the same one I'm thinking
Let's
about.
hear it. Let's
Okay.
hear it.
Anyway.
Well,
what
I
do you
just
got?
remember, Tyler, I think I was charging one day or something, or Tyler and I were both charge nurses on the 7th floor, and I remember I had to go on
worried.
break. I remember I had to go on break or something like that, and I was like, Tyler, man, this guy's got to go to the bathroom. Can you go and help him? Because I gotta go on break. And so Tyler was like, yeah, sure, no problem. We would help each other out all the time. So I go on break, and I come back, and Tyler's livid. When I come back to the desk, he was like, Steve, never again, and I'm going to help you with a patient. And I was like, dude, what happened? You just helped him to the bathroom. And he's like, he went bathroom across the whole floor, and I had to clean it up.
Yeah.
And I was like, oh, man, I'm so sorry. I don't think he ever trusted me again after
No,
that.
I did.
But,
oh, man.
but Tyler and I figured out there's a concoction that we use to help people go to the bathroom.
Okay.
Tyler figured out it's called the bowl.
Yes.
Okay.
Okay.
Oh.
So prune juice,
Uh-huh.
milk and mag,
Uh-huh.
Miralax.
Just
Warmed
Mix
up.
it together. How many seconds, Tyler? About 15?
15.
15 seconds in the microwave. Give it to patients. Works like a charm.
I'm telling you.
And Tyler and I figured this out, and that was one of our concoctions.
that
we
sounds
used all
like
the
a
time.
nightmare.
We-
In a bottle.
One of the nurses that when we first went onto the floor
Yeah.
did the prune juice and the milk of mag.
Yeah.
And we had the idea, well, let's add the Miralax
Yeah.
as well.
Ooh.
And we spiced it
Spice
up,
it
and
up a
I'm
little
telling
bit.
you,
Little umbrella in the drink.
We spiced it up. It
works like a charm. I'm telling you.
Tyler and I bonded over quite a few constipated patients.
Oh my
It's just
goodness.
the way it is, man.
Back to opioids, right? There you
Yeah.
go.
Yeah.
But yeah, that's Tyler. And, oh man, we have some good stories, but there's some other
forgot
ones. But
about
we'll talk about those out of this meeting.
I love that.
But as a nurse, I loved it. I was just in my element, and I thought it was super cool. And I got to go to Guatemala. This is kind of the thing that set me to be a nurse practitioner. I got to go to Guatemala, and I was helping a doctor down there who didn't speak Spanish. And I speak Spanish. I speak fluent Spanish. And I thought, being in Guatemala is amazing. Being able to help these people as a nurse, bare bones nursing, no orders that I have to follow. I just help these people the way that we need to be. We need to help them. And I remember he had a stroke patient. And I love working with stroke patients. Like, it was something I really enjoyed doing as a nurse and educating. I love to educate. And this doctor asked me to go on a house call in this tiny little village in Godinez, Guatemala. And she didn't speak Spanish. Mm-hmm. And my buddy and his buddy Reagan was with me. He's another nurse that is a great nurse. And he was with me
dude.
too. And we went out to this little home of this stroke patient, really bad stroke. It was ischemic stroke and flaccid on the right side, and family didn't know anything of how to take care of a stroke patient. I mean, they're in the middle of this tiny little town in Guatemala with no medical care, right? And the doctor was with me, and she's like, "Hey, we need to explain from A to Z stroke care for this patient. We need to give them medications. We need to give them aspirin and atorvastatin. We need to make sure that they take those medications appropriately to prevent future strokes. We need to teach them how to prevent pressure ulcers and how to roll them and how to make sure he's eating properly." And she's like, "And I don't speak Spanish, and you're the only one that does. So Reagan and I are going to sit in the corner. Go for it."
Mm-hmm.
And so I went through everything with him on stroke care for about an hour or a little bit more. And after that meeting with that family and helping them out and getting to know them, my doctor friend Laura, she turned to me and she said, "Steve, why are you not a nurse practitioner?" And I was like, "That's a really good question." I said, "I don't know. I never really thought about it." And she's like, "You need to be a nurse practitioner." And as I started to think about that, I thought, is there so many more things I can do? And I could help so many more patients. I have had ideas for a long time to help patients, but I can never get it to come to fruition because I'm a nurse that has to follow orders. And not that I'm opposed to following orders, but maybe there's some things we could try and do, and I could use that autonomy to help
Right.
more patients.
Yeah.
And it worked out. I applied to NP school, and it's where I'm at now, and I love it.
That's
Absolutely.
awesome.
I think I was born to be a nurse practitioner. I know that's cliche, but I don't
Is that what
know.
you say all the time? Is that cliche?
Like I think I was born to be a nurse practitioner. Like people are always like, "Oh, you're born to be this, you're born to be that." I'm like, I don't know.
I would attest that I think you were born to help people for sure. I mean, I just think, just knowing you as long as I have, man, definitely in the right spot. And I'm glad you are where you are because you needed that autonomy to spread your wings and be able to educate not only us but patients. So I think that's awesome, man. I'm glad.
It all started with a dog and a catheter.
Dude,
a
I'm
Chihuahua.
telling
So,
you,
I never
specifically.
know where life takes you, man.
Yeah.
man.
Yeah. Did he speak Spanish, the Chihuahua?
Yeah.
Yeah.
Works good.
That's awesome.
Understand a
you
little
guys
bit better.
connected real good, I'm sure.
Yeah, that's
I love
right.
that.
At first, I honestly thought you were talking about a Foley catheter
Well, I know I've done that too, but
on a Chihuahua.
on a Chihuahua. Yeah.
He's done it all, folks.
Dude, he's a wizard, man.
Well, what's super funny too is that
You
later
have
on,
to do that. You really do that to dogs? You put
Yeah.
a Foley in a dog?
yeah,
Dude, if
put a
you-
Foley in a dog. You know, the best place to put
Why?
an IV catheter
Yeah.
in a dog, just FYI, if you ever
Yeah.
want to put one in your dog, you just shave right here on the upper arm, and they got a really good vein right there. That's great. Yeah, sheep, their neck is the best.
That's it, huh?
So if you're ever out on a
Yeah.
farm and you need to draw blood out
I'm
of a
calling
sheep,
Steve.
just
Steve, FaceTime me here.
you
I'm
have to
trying
shave a little bit as
Yeah.
well.
You know what's so funny though too is like later on as a nurse,
Uh-huh.
I put in PICC lines and IVs for 2 years,
That's dude. I'm telling you, he's held
And-
so many hats.
Yeah.
and it was a
guy's everywhere.
blast. Like it was
Yeah.
super cool.
I
but
remember
was like,
seeing him. Coming. He's like walking down with the machine. He's like, "Yeah, we're going to throw a pick line in." I'm like, "Dude, what?" He's like, "Yeah, I'm on the pick team as well." I'm like, "Pick team, home health, med surge." I'm like, "Dude, well rounded."
I think that's cool part about nursing and medical school though is like medical stuff is like not medical school, but MP is you just kind of wear a bunch of different hats, and that's kind of fun.
That's
I
awesome.
think. So
Let's talk a little bit more about the geriatrics then.
okay, let's do it.
So,
Blood pressure and hypertension.
yes, we're going to talk about blood pressure as well as hypertension today. All of the comorbidities, all
Gotcha.
2 of them that I could think of on the spot.
Mm.
Um,
Hey, you ratted yourself out. I wasn't going to say anything. I was going to let it slide.
yeah. It would have come out.
Probably.
It wasn't going to come out. Comorbidities. That's,
Yeah.
I think, what everybody thinks of with the geriatric population, polypharmacy, and all the different chronic conditions you're treating. So what's kind of unique in your approach to address that? Because we were just talking about this earlier. I think everybody in every specialty in medicine is going to interact with a geriatric patient.
100%.
You've got a little bit of a unique lens of seeing them in that setting where you're trying to really oversee their safety and their transition back to independent living. What
Yeah.
are the things that you're considering there? What have you seen to be successful?
I think that's one of the big things with so geriatric. We're talking we'll say 60 and older, right? Fairly geriatric there. 90-year-olds get a little bit different than 60-year-olds, right? There's some variation within 30 years, 40 years, from 60 to 100. But from what I have seen, and when we talk physiologically, things start wearing down as you get older. Bones start wearing down, kidneys and liver start wearing down, heart starts wearing down, gastrointestinal tract starts wearing down. Things just start getting older, right? And so as things get older and we're on medications, that also puts a pressure or a changes the way that those organs work.
Yeah, it burns
So
the system.
It burns the system, right? That's a really good word. Burns the system. And so you really have to watch and make sure that what you're giving them medically, pharmacologically, is not causing more damage to them or causing more problems that they're going to see on the outside. For example, we have to watch Tylenol and ibuprofen for the kidneys and the liver, right? People take Tylenol all the time before the age of 60. Not a big deal. Pop a couple Tylenol, pop a couple ibuprofen, I got a headache, whatever. Yep. It's not that easy in somebody that's 88 and has kidney failure.
Yeah.
Or liver failure. We have to be avoid nephrotoxic medications because their kidneys suck.
Yeah.
Or their liver's having struggles. And so something as simple as we take for granted, like Tylenol, that we're like, it doesn't cause any problems in a geriatric patient. It could. Right? And that could set them up for failure if we use too much of it. No one wants to go into kidney failure.
Mm-hmm.
It's an awful disease, right? And so we have to watch with these geriatric patients. That's something that I look at as soon as they come in, is like, what medications are they on?
And
if they come from the hospital.
Have you seen the setting where somebody has printed out 6 pages of medications?
100%.
And what do you do with that?
I look at every single one of those medications and make sure that it's actually something that's appropriate for them.
Good.
Because I have to it's a balance, right? We have to make sure that they're able to progress.
Mm-hmm.
We don't want to give up on these patients. So progress physically and mentally. We have to make sure that, their time in a skilled nursing facility is short. And so I got to get them to point B, step B, after 20 days. And I have to make sure that they're well set up, right? A little different that what I do is that, so you might see how often do you guys see your primary care physician?
No comment.
I've actually been going annually.
So you go once a year?
Yeah, once a year.
That's right. How's your diabetes, by the way?
Oh, well, I need to follow up on that.
But you go once a year, right? Which is not very much.
Yeah.
Okay?
It's true.
So I'm seeing these patients 3 times a week for about 20 minutes at a time. And to help manage their care. More than they've seen their PCP in a long time. And that just is by nature. Insurance doesn't pay for PCP visits more than once a year. PCPs are super busy, right? They're seeing 40 patients a day. And so I have to make sure that what I'm doing is setting them up long term.
Yeah.
Because they may not get into their primary care physician. We like them to get in within 2 weeks, and we set that up for them. But whether or not after that 2 weeks they see him again for another year,
who knows?
It's hard to say.
Yeah.
Who knows, right? And so polypharmacy is one of those things that we really have to watch. Everything has a side effect. Every medication has a side effect.
I often will tell people when we're talking medications, because acute pain management is probably the thing that we do most commonly with oral medications. But if you think about it, every single medication is a calculated dose of poison.
Yeah.
Because anything, as whatever your intentions are, is good and as much as you're trying to help, if you take it in excess, it's toxic. It can be harmful for you. So somebody
100%.
has studied out the therapeutic range of take enough of it to where it helps you, but not too much to where it hurts you.
Right.
They all have their issues.
I'm managing patients that have peripheral edema because they have heart failure.
Mm-hmm.
But I draw too much fluid off them, and then their electrolytes dump and get bad. Or I draw too much fluid off them, and they get dehydrated. And then they don't want to eat and drink, and then their brain fog. I mean, it just is a perpetual, motion of trying to figure out what is the best balance to help with these patients. Not too much of anything to make sure that they're balanced and their body keeps moving forward. And, I touched on this a little bit earlier where it's like, you talk about pain medications. 95% of my patients that come in are constipated. They're brain fog because they're 88 years old and they have early stages of Alzheimer's or dementia. Not all of them, but everybody loses cognitive ability as they get older. They have heart failure, so they've got peripheral edema, and they're not eating well. They're all 95% of them are malnourished.
Mm.
And then they get an opioid from the hospital that stops them from eating, stops them from breathing well, stops them from
That's
drinking,
your fault, Alex.
That's
and
me.
brain fog.
Yeah, and constipation.
Right? And constipation.
Yeah.
And so we have to make sure that the medications that we're giving our patients or our parents, that our parents are getting, are not causing more harm to them because we want them to continue to progress.
Yeah.
And live as long as they can live that's appropriate for their time.
Yeah.
And so it's a kind of a fine line. And that's, I think, why I've jumped more to treating non-farm than farm. I know that medications have a place, but you also have to watch what medications do to people. And so if I can treat something like pain using non-opioids or medications that have less side effects, then that's one less medication that's going to cause problems to their Lasix or their heart failure medications or their stroke medications, you name it.
Yeah.
So it's a kind of a fine balance. It's like
I can see that scenario where somebody has had an injury or a chronic musculoskeletal condition that has incapacitated them, so they choose to undergo an elective surgery. And that's where we would interact with that patient, but we have not quite figured out painless surgery yet.
Right.
So coming out of surgery, there's an expectation to help
Right.
manage their pain, and that in its own world is a difficult situation to help somebody understand their pain and manage it appropriately. But then you're also adding to this problem of now you've increased their brain fog, made them tired and sedentary, and stopped their GI system. And so they're not really getting up and out of bed. And when they do get out of bed, they're at a falls risk. And then you've complicated their other health issues. But which side of the fence? Where do you draw the line? Where are you managing their pain appropriately, but also not exacerbating these other issues that they have? How do you find that balance there?
I think it's of course a different balance for every person, right? If you tailor your pain management to the patient itself, then maybe but that also takes time, right? I'm not expecting like you guys in your situation to sit down with every patient and go through every single medication and be like, okay, here's how we're going to tailor your pain medication, because you don't have time, right? I do though. Like I can do that. Like I can sit down and be like, all right, you're not eating well. You're not breathing well.
Mm-hmm.
You're foggy in the brain. Are you having these side effects? Yeah, I am actually. I don't feel hungry and I'm not breathing and I just feel like I'm out of it. Okay, well you're on opioids, which have these similar side effects. What if we tapered these down and added something non-opioid and tried it for a week? And then we can add on ice packs and lidocaine patches and muscle rub, and we can add on physical therapy. And I'm going to give you protein drinks twice a day because you're malnourished. And protein will also help with the pain. And let's just see how it works. And then I come back next week and, this worked, but this didn't work. Okay, let's take that off and let's try something else. Like, these are conversations I'm having on a daily basis 3 times a week.
Yeah.
But I don't expect my friends like you guys to have that, because you only see them for 2 days in the hospital, 1 day in the clinic, maybe follow-up visits, but you don't really have that time. But maybe we could, when they're with me, then I could try to do that. But the problem is how do we get that outside of the facility?
And here's the
right?
reality of it. In a perfect world, what you are doing is so crucial, but it would be even more crucial if we could find a way to implement something like this pre-operatively.
100%.
Because we talk about patient optimization, especially when we're talking about surgery. And I think once you move a patient down the treatment line so far, I think it even becomes more difficult for you to try to manage it on the back end. Imagine if we were catching some of these things beforehand and teeing them up so when they return to you, it would be more of a maintenance thing. And then our output data, because the other thing is, like you said, it takes time to understand what's working and what's not working. Your primary care physicians interface with these patients once a year, right? So they have a whole year, technically, to figure things out with the regimen that they put them on. But I was just listening to you guys talk, and it was just eye-opening, this thought of polypharmacy and why does it actually happen? And it's like, well, you think about each patient is interfacing with all these different specialties who are potentially prescribing them a medication with the intent to address a singular problem that they presented with. And then people we're habits, creatures of habit. So if somebody prescribes us something, we're going to keep taking it. Right. Somebody else is going to prescribe something, we're going to keep taking that. And then it gets into your lap and you're like, whoa, well, you probably don't need to be taking all of this. But then I had a thought of what happens once they go home and leave your care. Are they following back up with their primary care? Are you in any way coordinating with the primary care physicians afterwards when you've made a change to their medication regimen? What does that look like?
Yeah, and I think that you bring up a really good point is are the specialists talking to each other? More than likely not.
No. The answer is no.
Right? The answer is no, right? What cardiologist speaks to the primary care physician, which speaks to the neurosurgeon? It doesn't happen, right?
Right.
Could it happen? Sure. It could happen. Will it happen? It would take a lot of change, right?
Yeah.
But you're right. Like, they're prescribing all these different medications, but no one's speaking to the other specialist, right? Which could eliminate a lot of that polypharmacy.
Mm-hmm.
Could help a lot with these patients. And I feel bad. Like, as a former home health nurse, I saw these patients in their home, and I'd have to go in and help them with their polypharmacy as well, because they'd be like, I don't know, they just told me to take it. That's what I hear all the time. I don't know, they just told me to take it. Do you even know why you're taking it? No, cardiologist recommended it.
I can't tell you the number of times we've asked a patient,
why are you taking
what's
that?
your medical history? Oh, none.
know.
And then what's your medication list? Da 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 da. It's like,
Yeah.
Oh, well, you do have diabetes. You do have hypertension.
Right?
And blood pressure.
And blood pressure, right?
Yeah.
But so that is an issue. So one thing that I've tried to do is be very transparent, because I see this problem. This is a real life problem right now. Like, this is something I feel like the medical system is missing, is communication between specialists, right? Mm-hmm. One thing I try to do is I will reach out when a patient discharges for me. I try to reach out to the PCP and say, hey, I'm seeing this patient. I've been seeing him for this long. These are some concerns that I have. These are some labs maybe that I would recommend that we check in the next 2 weeks. I just want to give you a heads up.
That's awesome.
That's great.
And I try to do that when my patients go to the ER. I try to call the ER doctor and be like, this is what I've done. This is what I'm concerned about. Because I sometimes have to send my patients back to the ER because something's going on. And nothing's quick. If you want to learn anything about the sniff, nothing is stat. I can't order stat labs are 4 hours to 8 hours. X-ray is 12 hours.
Yeah.
Like, if I want something done quick, I got to send them to the ER to get it
What
done.
about some lunch? You get lunch stat?
No.
Sniff?
No.
No?
They
don't give him
get
lunch.
Stat. No.
So you got to eat outside, my
What
guy.
about the patients?
But nothing is stat. So, like, if I send them to the ER, I'll call the ER and I'll be like, hey, these are my concerns.
Yeah.
Can you check this out?
Yeah.
Tell me what you think. I don't know what to think about this. Or I'll reach out to other specialists and be like, not 100% sure. Cardiology is not my specialty, but XYZ's going on. I have a gut feeling something's going on. Can you consult with me and can you help me out with this? So I do try to make an effort, but I'm only seeing patients at 2 facilities.
Yeah.
How many facilities are there in Utah?
More than 2.
And are they all ran the same?
Are they all ran the same? Are they all doing the same? So I definitely think, Tyler, that your idea of pre-surgical polypharmacy education prior to procedures, even if it started small like at Summit, how many patients you could reach, how many patients we could reach to create this so that patients are better off following surgery, and would that trickle on down the line? Mm-hmm. I think you have to start small somewhere to gain to get that ball rolling, right?
Yep.
And eventually you hope that it'll turn to something cool and something that will actually help more people. But I think it's a great idea. I think it's something we should explore.
I think so.
You got it.
I think so.
But did that answer your question?
Answered them all, Steve.
Well, I don't know if I
nailed
answered
it.
them all, but geez.
You got them all.
I mean,
Even the question of, was it a Foley catheter in that Chihuahua?
And he's like, yeah, of course.
both.
Didn't even hesitate.
Hey,
At the same time.
to be honest, Alex, if it can be done to you, it can be done to a Chihuahua.
Oh,
So,
my goodness.
Does a Chihuahua need a Foley? What would they? Come on, guy. People get sick. Dogs get sick.
I guess.
Oh, man.
I guess
You
that's
have
whole
a
new-
dog, too.
I do, yes. And
if you ever need help, just holler at me.
okay,
I'll
all
help
right.
you out.
When we need a Foley placed, I'll let you know.
I'm telling you, though, vets, man, they make some money. I took my dog, a mini Australian Shepherd,
Yeah.
eating a bunch of rubber bands. Got all tangled in its gut. Had to go in an open abdominal surgery. $3,800.
I've done
Like,
that before.
Woo. But you know what? Saved my dog's life. So
And your
Gotta
kids
have
are
it.
happy.
and my kids are happy.
That's
Well,
what you do.
let's wrap up here. What do you say?
Yeah, let's do it.
What'd you learn today, Ty?
Dude, why are you asking me? This is my friend. This would be me asking you.
Because we started that the first episode, and now we do it every time.
Oh,
That's
okay. Creature of habit.
Yeah, exactly.
All right.
Exactly.
Well, I think today we did have a great discussion, and I appreciate the insights from Steve. He's a good friend of mine. He's been, a loyal guy to the community, if I'm being honest. He's been an educator since day one, and I think brought a lot of good information to the table of how we interface with our patients and how we can have a collective mindset on treating the patient as a whole. And I think sometimes we as providers in our own subspecialties get a little bit tunnel focused, if you will. And I think looking at the patient as a whole and treating the body as a whole is going to be super imperative for a successful outcome, regardless of what situation we're in or where we're trying to get our patients to. So I really appreciate the insights. Obviously, love the fact that you brought your vet skills to the table, your passion for fishing, and just your overall good sense of humor, and really appreciate you. So thanks for coming on today.
Thanks for having me. What'd you learn, Alex?
Oh, yes!
That's the first time that's ever happened. He just took the whole answer.
Yes, sir.
I learned that high blood pressure and hypertension are the same. That's my take.
Mic drop. No, it's been good. I appreciate you guys having me on. It's been a while, so I'm grateful to be here. But I learned something from you guys all the time as well. So grateful we're able to have a fun discussion and relax.
Where can people reach you or connect with you? Are you on the World Wide Web?
Come meet me on the Provo River and we'll go fishing.
That's where you can find it, on the Provo River.
Alex, we're gonna have to go fishing.
Apparently. With Summit, you can find us online. YouTube is the Summit Medical Institute. Instagram is Summit Brain, Spine, and Orthopedics. And then, like Steve mentioned, Tuesday mornings, Mountain Point Hospital in Lehi, Utah. 7 a.m. Come and catch up with us. Shout out to the production team hanging out with us down in Amelia. And shout out to my guy, Tyler Murray, always hanging out with us. Anything else you want to add?
I think that's it, man.
All right, let's shut it down. We got some good ones coming up, though. We've got, we're going to get the boss on the show again.
Yes, sir.
The man, the myth, the legend, Dr. John Edwards.
He's trying to avoid us, but we're going to get him.
I know.
We're going to get him.
And we're going to have a rematch with Story Time. That's going to come up as well, so stay tuned for some good stuff. But we'll catch you next time. I'm Alex Davis.
I'm Tyler Murray.
Peace.